Good evening, everyone, and welcome to our second broadcast, our second webinar on behalf of Northeast Ohio Liver Alliance. It is really a pleasure to lead this new venture in Northeast Ohio. Some of you might wonder, what is Northeast Ohio Liver Alliance? We are a nonprofit founded in 2021, and the goal of this nonprofit organization is to educate healthcare professionals and laypersons alike about liver disease, to advocate for resources, policy changes, and public health interventions that prevent and positively impact liver disease, and also to support the research and public health interventions that benefit persons living with liver disease. As part of these functions, we are proud to have series of webinars to really address some of the more common and up-to-date information regarding common liver diseases. It is my pleasure tonight to have Dr. Naim Alkhouri join us and speak to us and educate us about fatty liver disease and what lies ahead. Dr. Naim Alkhouri is one of the thought leaders in fatty liver disease. In fact, he just contributed to the American Association of Study Liver Disease seminars and recent program that ended just earlier today, and he was very crucial in discussing issues related to research update in that field. Dr. Naim Alkhouri is trained in Cleveland, Ohio. He practiced hepatology in this area first, meaning Cleveland, and then he joined the Texas Liver Institute, and more recently joined the Arizona Liver and became the director of fatty liver and metabolic diseases in that institution and chief of transplant hepatology. His experience is wide in that field and other fields related to hepatology. We also are proud to have him part of our program here in Ohio called Clinical Research of Ohio, and he is also director of fatty liver program in North Shore Gastroenterology. Without further ado, I would like to introduce Dr. Naim Alkhouri, and would love to hear him talk to us about fatty liver tonight.
Thank you so much, Dr. Tabar, for the kind introduction. It's always good to be with the good people of Cleveland, Ohio. And I'm very excited for you guys to start the Northeast Ohio Liver Alliance. This is a very high unmet need for the community, and it is an honor to be part of it. So the task that was given to me today is to talk about non-alcoholic fatty liver disease, what lies ahead, and what does the future hold for our patients. These are the objectives for this talk. So first, I'm going to start by dispelling 3 misconceptions related to fatty liver disease. The first one is that although fatty liver is common and it affects about 25% of adults, Nash, the aggressive form of fatty liver, is not that common. It affects only 3 to 5%. And I will show you new data that Nash is probably more common than what we thought earlier. The second misconception is that only patients with Nash and significant fibrosis are at risk of developing liver-related outcomes. This means decompensation with ascites, encephalopathy, variceal bleeding, needing transplant. But patients with fatty liver or simple steatosis without Nash, without significant fibrosis, typically don't progress to liver outcomes. And I'm going to show you new data that even patients with simple steatosis have higher risk of developing liver outcomes. And then the last misconception is that we have to do 2 biopsies to assess for response to treatment, and this is the only viable outcome to approved NASH drugs in clinical trials. And I'm going to show you an alternative way to show benefit for these patients. And then after this, I'm going to spend a few minutes discussing the new therapeutic agents in development for NASH, including combination therapy. The pipeline is robust and the future looks bright for our patients, so I wanted to share some of the excitement with you guys. Follow me on Twitter, and we also have a TikTok account if you want to watch some short videos related to liver disease and new technologies in hepatology. So the first misconception is that NAFLD is common, but NASH only affects 3 to 5% of middle-aged adults. We've all seen this slide looking at the global prevalence of NAFLD and NASH. We estimate that about 25% of adults have NAFLD on a global scale, with the highest prevalence is in South America and in the Middle East. But the general consensus has been that NASH only affects 3 to 5% of the general adult population. So here I'm sharing with you new data from a study we just published in the Journal of Hepatology, looking at the prevalence of NAFLD, but more importantly NASH, in middle-aged Americans, and this was done prospectively in the city of San Antonio, Texas. So what we did in this study, we had middle-aged Americans coming for their screening colonoscopy. No known history of liver disease or elevated liver enzymes, no excessive alcohol consumption or viral hepatitis, and they had no idea that they had any liver disease. Then we offered them the option to know more about their liver health. So when they did the colonoscopy class, we just said, would you like to know more about your liver health? And if they said yes, we gave them a consent, and then we did a specialized MRI called MRI PDFF that can quantify liver fat very accurately. And then if they had more than 5% liver fat on the MRI PDFF, we called it NAFLD, but then we offered them a liver biopsy to look for NASH. NASH is diagnosed by finding steatosis plus inflammation plus hepatocyte ballooning. And with the biopsy, we can also assess for liver fibrosis. So what did we find? We found that if you take 100 middle-aged Americans, again, without any known liver disease, that 38%, not 25%, 38% had evidence of NAFLD. But more importantly, out of the 100, 14% will have NASH. So this is almost, triple the prevalence of NASH that we were told before. And this is very important because we think NASH is the aggressive form of fatty liver disease. So a substantial percentage of middle-aged Americans that are asymptomatic have a significant liver disease that can be progressive. We then did some subgroup analyses. So as I mentioned, again, 38% of the population had NAFLD, 14% had NASH. But just by looking at Latinos, Hispanics, we found NAFLD in 55% and then NASH in 25%. So 1 in 4 Latinos that are middle-aged will have NASH. Then we looked at patients with type 2 diabetes, and we found that NAFLD was present in 70%. So if you're in primary care and you're taking care of patients with type 2 diabetes, you need to know that NAFLD is very common and you should be screening for it in every diabetic patient. And the American Diabetes Association recommend that you check liver enzymes in all diabetics, and then if there's any evidence of liver disease, you follow up with an ultrasound at least, if not other imaging modalities. And then we looked at NASH and diabetes, and we found it in 36%. And then we looked at a combination of risk factors. So Hispanic with obesity and type 2 diabetes, metabolic syndrome. And we found NAFLD in 92% and NASH in 46%. So these are, very alarming statistics. Of course, the study was done in San Antonio. There's overrepresentation of Hispanics, Latinos. Obesity, type 2 diabetes were more common than the national average. But again, these are very alarming statistics, and NASH is more common than we thought before. The second misconception is that only patients with NASH and significant fibrosis, and by that I mean stage 2 or higher. Typically we divide fibrosis from stage 1 to 4, which is cirrhosis. So only patients with NASH and F2 or higher are at risk of developing liver outcomes. Now, this is the classic NAFLD spectrum that we show in every lecture on NAFLD. We start with simple steatosis, then you progress to NASH with ballooning inflammation, and then fibrotic NASH is defined as the presence of NASH plus F2, F3 fibrosis, and NASH cirrhosis is the presence of F4 fibrosis. We've had several studies, and here I'm showing a study from Europe showing that in terms of developing severe liver disease, liver-related outcomes, that the hazard ratios don't become statistically significant until you get to stage 2 or higher. And then, of course, once you get to stage 4, the risk goes up exponentially. But these studies were relatively small, and we have data from the United States, and we have multinational data showing the same thing. But at the end of the they included about 600 patients with biopsy-proven NAFLD and Nash, and they did not have that many patients with very advanced disease, and the duration of follow-up was also not very long. So these are all limitations and may have, skewed what we know about the natural history of NAFLD and early Nash. So there was a recent paper published this year in Gut looking at a very large cohort from Sweden. They all had biopsy-confirmed NAFLD, and they included over 10,000 individuals. So this is definitely the largest cohort to date. Because in Sweden, they have a project called Espresso, which is basically an epidemiology project where they actually can look at all the biopsies done in the entire country of Sweden at the 28 pathology departments. So they found every single liver biopsy done for NAFLD, and then they matched these 10,000 individuals to each patient to 5 subjects from the general population without evidence of NAFLD, and they matched them for age, sex, calendar year, and county. So the total study population was around 60,000 individuals. Now, what did they show? They showed first that compared to the general population, that even patients with simple steatosis had increased overall mortality. And then they showed that, yes, NAFLD was associated with increased mortality, but then the mortality was higher if you have Nash without fibrosis, and then even higher if you have fibrotic Nash, and then the highest mortality was in patients with cirrhosis. But the key new finding here that patients with NAFLD had higher mortality than the general population. Of course, some of you might be saying, yeah, they died, but they died from cardiovascular disease because they're obese, they have type 2 diabetes. But they actually did further analysis that looked at the cause-specific mortality. So they divided the cause of death into 4 major categories: extrahepatic cancer, cardiovascular disease, cirrhosis and its complications, and then hepatocellular carcinoma. And what I want you to focus on is just simple steatosis. So these are the patients we said there have very low chances of progressing to cirrhosis and liver cancer. But what they found in this study, that if you look at the multivariable adjusted hazard ratio, that the hazard ratio for developing cirrhosis in patients with simple steatosis was 9-fold higher than patients, than subjects from the general population. So this is very concerning. They also found the risk of liver cancer, hepatocellular carcinoma, being at 7-fold higher than the general population. Of course, the risk of liver cancer was higher in patients with advanced fibrosis and cirrhosis. The risk of developing cirrhosis complication was higher in patients with fibrosis, but still, patients with simple steatosis don't follow a benign liver course. They have higher incidence of cirrhosis and liver cancer, and they die from these complications. So I think the whole concept of reassuring patients with simple steatosis that they're not going to have liver-related outcomes is actually not very accurate, and we need to reconsider what we counsel in the clinic. The third misconception is that, to approve drugs for Nash, to show efficacy, you need to utilize histologic endpoints. You need to do biopsy at baseline and then do the therapeutic intervention, repeat the biopsy at the end, and then show improvement on biopsy. And we've been told that this is the only viable way to approve drugs by the FDA. And the FDA efficacy endpoints for phase 3 trials are 2 main endpoints. One is Nash resolution on repeat biopsy. So, on the initial biopsy, you need to have steatosis, inflammation, and ballooning to call it Nash. But then on the repeat biopsy, you cannot have any ballooning. You can only have mild inflammation. And this is what we call Nash resolution, without, of course, worsening in fibrosis. Or the second primary endpoint could be fibrosis improvement by 1 stage. So if someone has stage 3 fibrosis and on the repeat biopsy you show they have stage 2 now, this is considered a response and without worsening of Nash. Or you can meet both of them, of course. So this is the pathway for drug development. If you want to get a drug approved by the FDA, this is what we have to do today. Now, of course, doing liver biopsy in early phase trials is not feasible. You want to at least see some efficacy of the drug before you take it to a histology trial. So that's why we have several non-invasive tests that potentially correlate with histologic improvement. The most validated one is actually reducing liver fat on MRI PDFF by 30% relative reduction from baseline or more. This has been shown to correspond with improvement in histology. Recent data show that even improvement in ALT potentially could predict response to histology if you reduce your ALT by 17 units per liter from baseline or more. And then we have several methods to measure liver stiffness: MR elastography, corrected T1, liver stiffness on FibroScan, and these thresholds that correspond with histologic improvement are starting to emerge. So maybe reducing your MRE by 15% from baseline, your CT1 by 88 milliseconds, and reducing your liver stiffness on FibroScan by 20 to 25% may also predict response. But the FDA does not acknowledge any of these endpoints to approve a drug. So these are meant for early drug development, and we still need to do biopsies to qualify any drug. So I want to share with you some recent data that we just published in JAMA with the team from the Cleveland Clinic, the bariatric surgery team with Dr. Ali Aminian. And this is what we call the Splendor study: surgical procedures and long-term effectiveness in NASH disease and obesity risk. So this was a retrospective study on patients with biopsy-proven fibrotic but non-cirrhotic NASH, so NASH with F1 to F3, to investigate the effects of metabolic surgery or bariatric surgery versus standard medical care on the development of major adverse cardiovascular events, MACE, and also major adverse liver outcomes. Now we call it MALO. Malo in Spanish means bad, so it's bad to have these major adverse liver outcomes. That means development of ascites, encephalopathy, variceal bleeding, liver cancer, etc. So again, this was a retrospective study. Everyone had a biopsy. Everyone had NASH with F1 to F3 fibrosis. They were matched. They're followed over a 10-year period, and the primary endpoints were actually cardiovascular events and liver events. And I think this is more important than just showing NASH resolution on a biopsy. It's more important than regressing fibrosis by one stage, because these are the outcomes that matter to patients. And these are the baseline characteristics. So we had 650 patients in the bariatric surgery cohort, matched to 508 non-surgical control. They were matched very well for age, gender, type 2 diabetes, the disease severity. The only thing that was higher in the bariatric surgery group was the BMI, as expected. And this is what we showed in this study. In terms of major adverse cardiovascular endpoints, MACE, there was clear separation between the surgery group and the non-surgical control. If you look at the hazard ratio over a 10-year period, there is a 70% reduction in cardiac outcomes in the surgery group. And the number needed to treat was about 7 patients to prevent one MACE event. So this is, highly statistically significant. And then more importantly, in this study, we're able to show clear differentiation in terms of major adverse liver outcomes. So again, you can see the surgery cohort and the non-surgical controls with clear separation. And actually, we reduced the hazard ratio by 88%. And the number needed to treat to prevent one liver outcome was 8 patients. So not a high number, which is good. So I think this is very encouraging. I think it shows that, relatively, it's a large sample size, but it's not in the thousands. The separation started around year 5. So I think potentially we can start thinking about designing trials that look at hard outcomes and really bypass the biopsy and all the issues related to biopsy, because the pathologists don't always agree on the reading. We don't always get the same severity of NASH or a stage of fibrosis. And at the end of the day, a biopsy is a surrogate for these outcomes. And if you are able to show improvement in outcomes, that's way more important than just improvement in a biopsy. Now, when you look at how did surgery help, we think that was mediated by weight loss. So if you look at the average weight loss with metabolic surgery compared to a non-surgical control, you can see a significant difference. They lost around 20% of total body weight with the surgery compared to about 5% in the non-surgical control group. And then there was also significant improvement in A1C in the surgical group. All right, so these were the three misconceptions that I wanted to discuss. I hope I showed you that NASH is more common than we think in middle-aged Americans, that we can potentially design trials based on outcomes, and that I don't want you to reassure patients with simple steatosis that they're not at risk of having any liver events. In fact, if you follow them long enough, they have increased risk of cirrhosis and liver cancer. And age is very important. If you have a 20, 25-year-old with Nash and stage 1 fibrosis, or even simple steatosis, this is someone I'm concerned about compared to a 75-year-old with simple steatosis. So the younger they are, the more likely they will have enough time to develop liver-related events. Now let's talk about future treatments for Nash. So to understand the new medications, you need to understand what leads to disease development and progression. And the first step in NAFLD development is really lipid loading into the liver. And this comes from different sources. One major source is actually the adipose tissue and the process called lipolysis, which is mediated by insulin resistance. And if we can, improve insulin sensitivity at the level of adipose tissue, reduce weight, obviously we can decrease the amount of fat going into the liver. But the other process that's very important is de novo lipogenesis, which is the production of lipids, fatty acids from glucose. And this process is a complex process, and this is what you see on the right. This is the de novo lipogenesis pathway and all the enzymes that are involved in converting glucose into pyruvate and then pyruvate into fatty acids that can be integrated into triglycerides. And believe it or not, today we can target each of these enzymes with different drugs that I listed here on the slide. So we can block the de novo lipogenesis enzymes and decrease the amount of fat going into the liver. Now, after the first step, which is the fat accumulating in the hepatocytes, these hepatocytes become more susceptible to secondary hits, including hepatocyte apoptosis, programmed cell death, that can induce the activation of hepatic stellate cells. These are the fibrogenic cells leading to fibrosis. There's increase in oxidative stress, and there's increase in liver inflammation and recruitment of inflammatory cells into the liver. So we can actually target all of these steps. We have hepatoprotective agents, we have anti-inflammatory agents, and then we have anti-fibrotic agents. So when we look at the therapeutic landscape for NAFLD, I divide the medications we have into three major categories. The first one is metabolic drugs that work on weight loss, insulin sensitivity, and de novo lipogenesis. The second category is hepatoprotective and anti-inflammatory drugs. We call them just anti-inflammatory drugs. And the third category is anti-fibrotic drugs. And this is the Nash drug development pipeline. We can target really every step of disease development and progression, again, through insulin resistance and affecting lipid metabolism to lipotoxicity, all the way to inflammation, cellular death, and fibrosis. And in the next few minutes, I just want to share with you some promising results from phase 3 programs. And if these trials are positive, we anticipate filing for possible FDA approval. So we have 4 main drugs in phase 3 development. I'm going to share with you 2 slides on each. One is called Rasmiter, Semiglutide, lanifibranor, and Obeticholic acid. So let's start with Rasmiter. The name comes from a resolution of metabolic syndrome. So they put all of these in one word, which is Rasmiter. This is a selective thyroid hormone receptor beta agonist. So we know that, the thyroid axis starts with, the pituitary gland releasing TSH to stimulate the thyroid to produce the thyroid hormones. And the thyroid hormones signal through nuclear receptors. We have the thyroid hormone receptor alpha and beta. Now, I can tell you, if we give patients synthroid, thyroid hormones, we can induce weight loss and we can reduce liver fat. The reason we don't do this is because they would develop thyrotoxicosis with cardiac adverse events, bone loss, and obviously it's not a good idea. What turns out that the thyrotoxicosis is mainly mediated by the thyroid hormone receptor alpha, and the positive metabolic effects of the thyroid hormones are mediated by thyroid hormone receptor beta, THR beta. So resmetirom is a THR beta hepatic selective, and it should not be associated with the same thyrotoxicosis adverse events that you would see if you just gave thyroid hormones. So in a phase 2B study that I was part of, we enrolled 125 patients, did MRI PDFF liver biopsy at baseline, repeated the MRI at week 12, then we did the MRI and biopsy at week 36, and then we had an extension open label arm. And to simplify the figures here, I just wanted to focus on the high dose resmetirom and the light orange. And what you see here in the figure on the left is the relative change in liver fat on MRI PDFF. You can see with the high dose resmetirom, we reduced liver fat by 42% from baseline compared to only 9.6% in the placebo arm. I mentioned this, reducing liver fat by 30% from baseline or more as a threshold for response. And with the high dose resmetirom, 75% of patients achieved that 30% relative fat reduction compared to 18% with placebo. And then if you look at patients that reduced their liver fat on MRI, 39% had Nash resolution after 36 weeks. So, these were promising results. The drug is now in phase 3 clinical trial. We completed enrollment and we have to treat the patients for 1 year, repeat the biopsy. We should have the results by the end of next year. And if the results are positive, we should anticipate filing to the FDA by early 2022, 2023, and hopefully FDA approval by summer of 2023. So this could be one of the first drugs approved for NASH by the FDA. The second drug is lanifibranor. This is what we call a PPAR agonist. Now, you guys are familiar with PPAR alpha agonist. This is the target for fibrate. So fenofibrate is a PPAR alpha agonist, decreases triglycerides. You're also familiar with PPAR gamma agonists, such as pioglitazone and the glitazone medications that were popular for diabetes, but they're not that popular now because they can cause weight gain and potentially also bone density issues, fluid retention, worsening heart failure. And then there's a PPAR called PPAR delta, which is more hepatic specific and plays a role in decreasing liver inflammation, and potentially it has anti-fibrotic effects. So lanifibranor is a pan-PPAR agonist. It's a PPAR alpha, delta, and gamma agonist. And these are the results from the phase 2B study that we did and we just published in the New England Journal of Medicine. We had about 250 individuals, biopsy at baseline, and then biopsy after 6 months of treatment with lanifibranor, low dose and high dose. And if you look at the high dose lanifibranor, there was Nash resolution in 45%, fibrosis improvement by 1 stage at least in 42%, and then a resolution of Nash and improvement in fibrosis by 31%. All of these were significantly better than what we saw in the placebo arm. So these are very encouraging results. This is also in phase 3 now, but the patients did gain weight, and this is because of the PPAR gamma effect. The next medication is semaglutide. This is a GLP-1 agonist. You guys have it available for diabetes, but also in high dose for obesity under the name Wegovy at 2.4 milligram weekly. So this was a study done specifically for patients with NASH, with and without diabetes, with semaglutide, and they had different doses, but I want you to focus on the high dose. This was daily dosing, 0.4 milligram once daily, which is almost the equivalent of the 2.4 milligram weekly. And in terms of Nash resolution with semaglutide after 72 weeks of treatment, we noticed that there was a Nash resolution in 59% with the semaglutide high dose, and this was significantly better than placebo at 17%. This is one of the highest rates we've seen in terms of Nash resolution with the single agent. But the issue is we did not see improvement in liver fibrosis. So this was mainly Nash resolution. And this is a limitation if we're going to use this drug for patients with more advanced disease like stage 3 and 4 fibrosis. But otherwise, they lost weight. It has cardiovascular benefits. It improves dyslipidemia. So obviously, semaglutide is potentially a great option. The last medicine I want to mention today is obeticholic acid. We started this program a few years back. This is an FXR agonist. FXR is another nuclear receptor that senses bile acids and regulates bile acid synthesis. Bile acids have several roles in our body, not just fat absorption in the GI tract, but also they affect our metabolism, and they have anti-inflammatory and anti-fibrotic effects. And by modulating bile acid signaling, you can affect all these pathways. So the phase 3 trial that was done with obeticholic acid is called the Regenerate study. And this was a large study. We randomized patients to obeticholic acid, low dose 10 milligrams daily, high dose 25 milligram daily, or placebo. They had baseline biopsy and then biopsy at 18 months. And this is where we did an interim analysis to assess for efficacy. And these are the results of the interim analysis. And this analysis included about 900 patients or so. When we looked at fibrosis improvement by one stage and no worsening in Nash, this was achieved in 23% of patients on the high dose obeticholic acid, and this was significantly better than placebo at 12%. But the delta was only about 11% over placebo, and there was no effect on Nash resolution in this specific trial. But anyway, the drug actually met one of the primary endpoints specified by the FDA, which is fibrosis improvement by one stage or more that's significantly better than placebo. But the drug is not the easiest to take. It can cause pruritus, itching, in up to 50% of patients with NAFLD that were included in the trial, and pruritus was severe enough that it led to discontinuation of the drug in some patients. There was also worsening in lipid profile, increase in LDL cholesterol, and decrease in HDL cholesterol, which is obviously a concern in this obese and insulin-resistant population. And there was a signal of increase in cholecystitis, and that was in 3% of patients on obeticholic acid compared to only 1% in placebo. So when the FDA looked at the totality of the data, the benefit delta only 11% in terms of fibrosis improvement, the potential for worsening cardiovascular outcomes, the FDA decided to hold off on approval, and the company that developed obeticholic acid is generating more data now, and they're still hopeful to file again for the FDA with more patients included and more safety and efficacy data. So we will see what happens to obeticholic acid. Now, I showed you a few medications, and, it's becoming a little bit difficult to compare all these medicines, and that's why we developed a new card. I call it the Nash Drug Scorecard, and we just published this in a review paper in Hepatology Communication. So when I evaluate a Nash drug, I want to look at three things. First, I look at hepatic efficacy endpoints because, of course, we're developing drugs for liver disease, so we want to make sure it's effective in terms of liver outcomes. And we look at histology, Nash resolution, fibrosis improvement, but also the effects of the drug on non-invasive tests, such as reduction in liver fat on MRI-PDFF, decrease in ALT, some fibrosis imaging tests, and fibrosis biomarkers. So you have to look at the totality of hepatic efficacy endpoints. But then even equally as important is to look at the effects on metabolic syndrome and cardiovascular outcomes. So we want drugs that will help with weight loss, that will help with dyslipidemia and improve insulin sensitivity. And ideally, we want a drug that has proven cardiovascular benefits. And we want to avoid drugs that potentially can worsen cardiovascular outcomes. And then finally, you have to look at the adverse events that are specific to each drug. Sometimes we call them adverse events of special interest. So I shared with you pruritus, for example, with obeticholic acid. With semaglutide, the main side effect is GI upset and low tolerability in certain patients. So you have to look at the totality of the data, and we cannot be very myopic and just look at liver outcomes. And this is an example how you can use the Nash scorecard to compare different medications. And I think, we're gonna look at this more carefully once we have more FDA-approved medications. Now, I showed you all these medicines, but that have exciting trials and potentially possibility for approval by the FDA. But unfortunately, we had a few medicines in the graveyard already now. These are medications that failed in phase 2B or 3 trials, and they belong to each of the categories I showed you. So metabolic drugs, anti-inflammatory drugs, and anti-fibrotic drugs. So it hasn't been an easy path for us to develop new drugs for patients with NASH. But of course, with the burden of disease and the fact that I see patients with NASH cirrhosis and liver transplant for NASH on a weekly basis in my clinic, I think we need to keep pushing. And I'm very optimistic that within the next 2 to 4 years, we're going to have a couple of drugs to choose from. So I showed you the efficacy data with several of these drugs, and as you can see, the efficacy ranges between 20 to best case scenario upper 50%. So definitely there's room for improvement with what we call combination therapy. So if one drug is effective at 40%, another drug is effective at 30%, what happens if you combine the two? Of course, we cannot extrapolate and say it's going to be 70%. We have to do trials and see what happens. So I'm just going to show you next few slides a trial that I presented at the last liver meeting, not the one that just concluded, but last year, 2020, looking at the safety and efficacy of combination therapies. And here we included actually 3 drugs: semaglutide, cilofexor, and firsocostat. So the drugs were semaglutide, I mentioned earlier, because it induces weight loss and it has beneficial effects on NASH resolution. Firsocostat is a de novo lipogenesis inhibitor. Again, this is the pathway I mentioned earlier, how you can decrease the amount of fats being deposited in the liver. And then cilofexor is similar to obeticholic acid. It's an FXR agonist that modulates bile acid synthesis. So these targets, they have different roles within the liver and different liver cells. It makes sense to look at their combination. So this was the study design. This was a proof of concept study, roughly speaking, 20 patients per arm. Everyone got at least semaglutide, so there was no placebo arm, because the idea here that we wanted to see if adding the other hepatic-specific drugs, firsocostat and cilofexor, to semaglutide, are we going to get any additional benefit, or it's going to be the same as semaglutide monotherapy. We included patients with evidence of NASH and significant fibrosis, but we excluded patients with NASH cirrhosis. And this is what we showed in this study in terms of fat reduction on MRI PDFF. And let's focus on semaglutide monotherapy on the left, and then triple combination therapy with semaglutide plus firsocostat and cilofexor. There was significantly higher reduction in liver fat on MRI in the triple combination therapy. If you look at the percentage of patients that achieved that 30% relative fat reduction, it was higher in the triple combination also, so in the 90% range compared to 80% with semaglutide alone. And then we raised the bar. We're like, well, can we actually decrease liver fat by more than 50%? And this is where you really see the potential for that triple combination therapy. 85% of patients reduced liver fat by more than 50%. And then we took it even to 70%, and this was 30% compared to only 7% with semaglutide monotherapy. You can see the timeline of fat reduction. So it happened quickly at 12 weeks, so 3 months, and then it continued all the way to 6 months. So, very encouraging data that maybe combination will have added benefit to just semaglutide. We also looked at a score called the FAST score. This includes liver fat on FibroScan, liver stiffness as a reflection of liver fibrosis, and AST, the liver enzyme. And we showed that the combination arms had higher reductions in the FAST score compared to semaglutide monotherapy. So take-home message for me is, NASH is more common than you think, and NASH is still the aggressive form of the disease. So we need to be aggressive in screening patients that are high risk for NASH. As I showed you, if you just have type 2 diabetes, about 1/3 of these patients will have NASH and 70% will have NAFLD. So in my mind, everyone with type 2 diabetes, everyone with metabolic syndrome should have a simple liver assessment. Could be as simple as just checking their ALT routinely, but if you want to take it a step further, maybe doing a FibroScan screening for their liver. I hope I showed you also the new data clearly that even simple steatosis without NASH is associated with increased risk of cirrhosis and potentially liver cancer. So it's not benign. So again, when you see especially young patients with fatty liver disease and their liver stiffness is low, but the CAP score is high at 350, 360, don't say, oh, I don't need to see you, you're fine. Say, let's try to lose weight, let's repeat the FibroScan, but try to reduce their liver fat because they have many, many years to progress and potentially they can transition from a simple steatosis to a NASH phenotype and eventually fibrosis and cirrhosis. I also showed you the data from the bariatric surgery trial, and potentially this will lead to a paradigm shift in how we design trials in the future, and maybe we should be focusing on outcomes more than just histologic improvement. There are other outcomes that we can look at also. There's new data that patients with NAFLD, as the disease progresses, CKD becomes more common, and you have higher percentage of patients getting to that GFR less than 60. We have data on extrahepatic cancers, so all cancers, actually, the risk of them go down after bariatric surgery, and potentially some other effective treatments for NASH. And then the development of diabetes could be considered also an outcome. So when we treat NASH, we need to treat the whole patient. We need to think about cardiovascular outcomes, their kidneys, and of course, their liver. And then I showed you promising results from several drug development programs. I showed you the phase 3 trials, and every time you're in phase 3, it means that we've shown good efficacy data, reasonable safety. So as long as the phase 3 trial is positive, we should anticipate filing for possible FDA approval. So with this, I'm going to conclude, and I would love to take questions. Thank you. Dr. Taba, I think you're on mute.
Thank you very much, Dr. Alkhouri. That was an extremely informative talk. I appreciate it, and I'm sure everybody did. I will ask you in a minute about any take-home messages from your experience at the AASLD, but before I go there, I was struck by the fact that you mentioned how outcome studies are important as much as histological information. As a clinician, I always think of staging as a very simplistic way of fibrosis. So and we all know that within every stage, there's a spectrum. So even in stage F4, you have patients who their degree of stiffness determine whether they bleed or whether they have hepatocellular carcinoma. The stiffer the liver, the more likely they have these complications. Does the biopsy help with that, one? And two, has the improvement of fibrosis you mentioned been demonstrated to reverse actual cirrhosis? I mean, have patients with cirrhosis went from cirrhosis to bridging fibrosis or less?
Mm-hmm. Yeah, excellent question. Let me answer the second one first. So you're absolutely right that up until recently, we never showed any data that if you take someone from F3 to F2, that this will translate into improvement of liver outcomes, decompensation, needing liver transplant. But just a few weeks back, there was a paper published in Hepatology that looked at the drug development program of Gilead. They had 2 failed drugs called selonsertib and simtuzumab, but in the process, they looked at about 1,100 individuals, and all of these patients had actually F4 on biopsy. And out of these patients, they had about 170 or so that had regression from F4 to F3, although the drugs didn't help. So this included even placebo. So the rates were similar in placebo and the drugs. But out of 1,100, they had 170 that regressed. And then they actually followed them and looked at outcomes. And they showed that if you regress from F4 to F3 on biopsy, that the risk of developing outcomes, liver outcomes, went down by 7-fold. So there is merit to taking someone from F4 to F3. And this is recent, despite the fact that we've been in drug development since 2011, when the FDA gave us the path for drug approval. So I think, we still need to generate more data on, is Nash resolution a relevant endpoint? I think we all agree that fibrosis regression, from everything we know in liver disease, probably is going to translate into better outcomes, but I'm still not too sure about Nash resolution. And with the variability in biopsy, I think, it's backfiring big time, that we're getting to a point we might be actually rejecting drugs that might be helpful for patients just because they cannot meet that bar on a liver biopsy after 1 year of treatment. So Nash resolution, the pathologist reads are all over the place. Fibrosis regression in 1 year, maybe it's such a high bar that maybe we're asking too much of these drugs. So we'll see. I couldn't agree more that outcomes are more important for clinicians and patients and for the healthcare system, because this is when the cost of taking care of these patients goes up exponentially.
The second question, you're kind enough to really take a major role during the last liver meeting, and I wonder if you can share with us some of the highlights as it pertains to NAFLD in that regard.
Of course, I'll be more than happy to give you my take on the liver meeting. So I think 3 major areas that emerge in my mind. Number one is using artificial intelligence and machine learning to standardize the readings on liver biopsy. We've shown a lot of data now that pathologists don't agree on the severity of Nash. They don't agree on the presence of ballooning, and this can really devastate a clinical development program. So we have a lot of data from several companies, PathAI, HistoIndex, that we can digitize the slides and we can actually have an algorithm give us a score for Nash and fibrosis, and you get the same score every time you have the slide being read by the computer. It's not like a human pathologist, where the same pathologist can give you slightly different reading on the same slide on 2 different days. So I think this is going to be incorporated into most of the clinical trial development programs. The second big area is biomarkers. We saw a presentation by Dr. Arun Sanyal from a consortium called the NIMBLE consortium, where they are looking at the performance of several biomarkers in a large cohort of patients, and being very specific in terms of what patient population we're looking at, what context of use, and having a deeper understanding of sensitivity, specificity, positive predictive value, negative predictive value, disease prevalence. And I think these collaborative efforts will help us qualify biomarkers for FDA approval. The FDA just approved one of them called ELF, Enhanced Liver Fibrosis, and we anticipate this to become commercially available by January. So this is going to be potentially a game changer in hepatology clinics, and we will be ordering the ELF scoring on patients with suspected NAFLD. In my mind, it has higher accuracy than the fibro test, for example, and this has been extensively validated in Nash. Fibro test was developed in viral hepatitis. And then the last area is obviously therapeutics. We had a few drugs that failed, but we learned a lot of lessons from these failures. One was a drug called aldafermin. It's an FGF19 agonist, a very potent drug. It was associated with reduction in liver enzymes, AST, ALT, reduction in ProC3, a biomarker of fibrosis, robust reduction in MRI PDFF, and mild improvement in terms of Nash resolution. But the only thing they didn't meet was fibrosis improvement. And then, the company decided that based on the FDA endpoints, they don't have a viable path for, taking this drug to phase 3. And I think this is, one of the frustrations we have, that I worry that, these endpoints are making drugs that will help patients with fatty liver disease fail because they have to show histologic improvement. It's very difficult for me to say that a drug is not helping when I see reduction in liver fat, liver enzymes, and fibrosis biomarkers, just because the biopsy didn't show me that after a short period of treatment. So I think we learned from the failures. There are a few drugs that showed very robust efficacy in phase 2A data, reducing liver fat as much as 70% within a few months. So I think the future is looking good. But I think next year is going to be even a bigger meeting, because potentially we'll have the results of the Maestro Nash trial with Rasmiter. This could be a major game changer in the field.
Maybe a tough question to answer, but what's your prediction in timelines when we're going to have something that we can treat our patients with? A year, 2 years, 5 years?
So, with obeticholic acid, as I mentioned, they met the fibrosis improvement, but the totality of the data was not convincing for the FDA. So now they have more biopsies, more patients, and more safety data. So they're putting all this together, and they're going to file to the FDA by January. And depending on what we learn from the new data, plus they have a phase, advanced cirrhosis trial called the REVERSE trial. If that one is positive, and then if the results from the extended analysis showed, similar efficacy or even higher efficacy and less issue with safety, maybe we will have something by summer of 2022. This is best case scenario. The next in line would be Rasmiter, summer 2023, and then Semiglutide, lanifibranor. They're just enrolling patients now, so I think it's going to be toward the end of 2024. So this is the timeline for what we have in phase 3 now.
Well, thank you again. This has been really, really very helpful to all of us, and appreciate the time. On behalf of myself, the board of Northeast Ohio Liver Alliance, and the audience, I thank you for this webinar, and we hope to see you again in future webinars. Thank you again, Dr. Alkhouri. Appreciate it.
So much, Dr. Tabar. Congratulations on Northeast Ohio Liver Alliance.
Thank you. And that concludes our webinar today. Appreciate everybody's attendance.